Good afternoon, everyone. Thank you so much for joining us. I know everyone's had a very busy day. I'm glad everyone was able to get something to eat and join us for today. My name is Amanda McClelland. I'm the Senior Vice President of the Resolve to Save Lives team. And I would like to welcome you to the launch of our Epidemics That Didn't Happen report. This is our third report and an important flagship report for Resolve as we celebrate the success of public health. Too often we are focusing on where we fail, the big after-action reviews, West Africa Ebola, COVID, yellow fever, the ongoing cholera outbreaks. We all know when we haven't got things right. Today is about putting the focus on when we do get things right and making sure that we can do that more consistently to show the impact and the importance of public health. Every day, people like us and the people that we support are out there on the front lines finding outbreaks and responding to keep our communities safe. And today's report is really to shine a light on the success of public health and the work that we all do. To that regard, it is my absolute pleasure to ask the Honourable Minister Minister of Health from South Sudan to join us today to discuss South Sudan's experience in this space, and then we'll facilitate a short discussion around some of the case studies included in the report today. So enjoy your lunch, and with that, Honourable Minister, please join me.
Thank you so much, Amanda. I would like to take the opportunity to appreciate the ancestral members of this land and their descendants, and also to acknowledge that I also come from an ancestral background, and I do appreciate my ancestors for the opportunity that we are here today. I also like to appreciate the organizers for inviting my team and I, as well as the many other participants that have come across the globe to be here for this Global Health Security Conference here in Sydney, Australia. I also like to appreciate the Government of Australia on facilitating us. It's not easy to get visas to attend such conferences. So let us please give Government of Australia a round of applause. We have had a little bit of the topic for this section, which is the epidemics that didn't happen, and the report that is about to be launched. But I have got this to say. We have been conditioned throughout the history to believe that epidemics outbreaks are natural. But are they really natural? In recent years, my country, as well as the rest of the world, have been battling COVID-19, Ebola, the risk of H1N1. Right now in my country, I have got an ongoing pockets of outbreak, and I honestly feel like a firefighter woman who is fighting pockets of outbreak throughout. It is not a pleasant thing to do. At the moment, we just finished on executing some measures in place to battle yellow fever outbreak, mainly in the western part of the country. And before I dive into it further, I would like to give you a little bit of a background of my country. South Sudan gained independence on the 9th of July, 2021. That is after the almost 5 years of ongoing conflict in the country. My mother was born in that conflict. Her grandparents were born in that conflict. I also born in the conflict, grew up in the refugee camp, and I became a leader just as the conflict was ending. And then we gained our independence, and from that time, I have been battling the aftermath of a post-conflict country, and it is very difficult to establish a functional healthcare system in a post-conflict country. I have got a little bit of political organization or the background for my country. South Sudan is organized into 10 states, 3 administrative areas, with the population of approximately between 13 to 13.7 million people. That is according to the projected statistic of 2023. And then, but the last census that we did was in 2008 when I was just doing my internship with the then healthcare system. South Sudan healthcare model is actually divided like this. We begin with the BOMA. BOMA is the lowest healthcare unit, to the primary healthcare unit, to the primary healthcare center, to the county, state, and the referral system, which is the teaching hospital. Recently, as I mentioned earlier on, we have been experiencing pockets of outbreak in the country. And in the recent years, my country experienced the longest cholera outbreak from 2013 to 2016. COVID-19 pandemic showed us that importance of building emergency preparedness and response. And now, the whole wide world is at the looming edge of the climate change impact. And I would like to bring to your attention that disease pattern is changing and it is increasing. At the very moment I speak, I am preparing for one of the worst flood that is going to take place in my country coming the rain season in June, July, and August. And at the same time, the country is also having an ongoing drought, a very massive drought. So a small country of 13 million is at the verge of going to collapse because part of it I'm dealing with extreme water and part of it I'm dealing with extreme dryness. That means that the diseases pattern is changing. The system that I have is going to be shaky. We have been accustomed to the illness, death, and societal or economic disruption epidemic are caused. But the world has made great advances in how we can find, stop, and prevent outbreak. Epidemics no longer have to be inevitable. We can now stop them before they can start. So what am I trying to get at? I'm trying to get at this. The epidemic that did not happen leads this way. This latest report that is being released today highlights how responsive healthcare systems are the bedrock of epidemic prevention. For example, inspiring stories of epidemic stop before early detection, early careful planning, and swift action. Paying attention and responding to signal from communities. Example also show that epidemics preparedness doesn't stop when an outbreak does. That is what we call post-epidemics preparedness. Consistency in investment and prioritization of preparedness are necessary to support strong responses to new as well as recurring diseases threats. Epidemics that didn't happen are, by definition, much less visible than those that do occur. Recently, we are vividly still traumatized, to say the least, from the recent ended COVID-19 outbreak globally. But continents like my continent, African continent, is every single day being faced with dealing with the realities of reoccurrence outbreak. It has become a normalized thing in my country to experience yellow fever outbreak every couple of months, to experience measles outbreak. Right now, I have got one or two states that is Upper Nile, Upper Nile State, Unity State, underwater for the last 5 years. They have got cholera outbreak every other month. It is a reality that I have to live with. That is our goal, is consistency working to keep outbreaks from spreading into the epidemics. But how do we avoid complacency? How do we avoid going on as business as usual? There always has to be a way of dealing with it. Just because we stop one outbreak doesn't mean that we have stopped the next one. And I have an example. In 2022, when I was just maybe a few months in the office, I had the most scare of my life when Uganda, on 20th of September 2022, declared Ebola outbreak in their country. Clearly, I'm one of the youngest ministers in my country, and as most of us in this room know very well, we don't have a school to go for you to learn to be a minister or for you to learn to be a president. You learn on job. And my job was in the eye of the storm, or I was put into the deep end of the swimming pool, and I clearly don't know how to swim. So I have to learn my way out. The best thing that helped us at that time was the emergency preparedness that my country had. My country is underdeserved in regard to the resources, just as most of the member states in the world, especially in the continent Africa. And for some of you who don't know, South Sudan is among the 6 countries that is named by the UN fragile states. What makes us a fragile state? It is not our making, but it is the reality that, like, I inherited a very non-functional healthcare system. And I mentioned yesterday, for those who were there, from the colonizers in 1950s to the then Sudan regime that ended the African longest civil war of 21, that resulted in the CPA of 2005, to the independence that I also took part because I was the executive director of Southern Sudan Referendum Bureau in 2011. So the point I'm hinting at here, the system that I inherited when I became a minister in 2020, the smallest preparedness that we had, coupled with the collaboration and partnership across borders. And as we know, epidemics do not know borders. Diseases do not choose where to go and how to go and who to impact. The Minister of Health, Dr. Jane Ruth Acheng, she tried her very level best to share in real-time data, and that how we were able to collaboratively work together using our system that is there to make sure that Ebola did not cross into South Sudan. Now, at that time, I had a question. What would have happened if Ebola disease would have crossed into South Sudan? I would have got a complete collapse of the healthcare system, because I do not have a self-sustaining system. I don't have an enhanced system. I don't have a system that has got a very good capacity. It is not my wishes that I don't have that system with very good capacity, but it is also because the investment in the system in my country is very low. As I have mentioned, we came out of a post-conflict era. So, but we also have to celebrate like the gains that we had. One of the gains, and the most important gains that I initiated when I took over this post, and I would like to say thank you to Amanda, and please can we give her a round of applause? She did a very good job. Last year, when I attended my second World Health Assembly in Geneva, I happened to have a meeting, a bilateral meeting with Amanda. And I sat and I was very honest with her. And throughout of that meeting, I established in my country 717 through her help. That 717, the importance and target of it is for the rapid detection and effective response in foundation for these efforts. In South Sudan, we applied 717 approach to an outbreak, as I mentioned earlier on, in the Western Equatoria region for yellow fever. We had an outbreak that we met every 717 target, and we analyzed every enabler and bottlenecks. That showed us that what we were doing, it shows us that we were doing something right, and at the same time, it also shows us where the gaps were. This helped us to make sure that, unlike past outbreak, early detection and decisive action prevented a more widespread, and it was able to be contained. We used the same modality in the recent outbreak of measles in some part of the country. I'm now using the same modality because last night I was up trying to look through the data to see should I declare cholera outbreak again in some part of the country while I'm in Australia or not. It is the same modality that we are using. So improving global health security means that no country is fully prepared, but all we have to do is to strengthen our preparedness capacity. The world needs to ensure that countries that have resources to make this a reality also need to know that diseases know borders. As I mentioned earlier on, an outbreak in one country can affect the entire world. Infectious diseases move faster And when I mean faster, we literally travel in the same plane. And earlier on, I had a bilateral meeting with our friends in US CDC. And I was saying that, we need to revisit some of the principles that were set 30, 40 years ago. Pretty much some of the principles are old as I am, needed to be revisited. Why? Because we have become a global village. Like tonight or tomorrow night, I will leave Australia, and then by 1 p.m., I will be addressing my government in my country. What if I go and whichever disease that I pick up here, I take it over there? So like literally, that means that we need to think differently. We need to revise, and we need to look at it that it's not going to be business as usual. In closing remarks, outbreak may be inevitable. There are always emerging new diseases or resurgence of old ones. But experience in South Sudan and many other countries, as I have highlighted, show that epidemics are not there forever, but we will always have to prepare and plan for them. We have the tools to stop epidemics in their tracks, as shown in the case studies that is going to be highlighted today. Preparedness and swift action works, but we must consistently work at it to make it happen. And as I mentioned yesterday, at times we come to the international forums, at times we will sit in the political halls, and we'll have got very nice fancy PhD sitting with us to prepare the document, but we do not execute them. So could we move away from making sure that we just talk and we sit on theories and make sure that we implement? When we recognize outbreak earlier and respond promptly and effectively, we can decrease the spread of diseases and save lives. As I mentioned, the next outbreak is waiting to happen. We don't know when. And then that outbreak is not going to choose. It won't choose continent Africa. It won't choose, South Asia or North America. It can happen anywhere. So can we please be ready? Thank you. Be blessed.
Thank you so much, Minister. And with that, I'd like to invite the panelists to the stage. You'll notice there's no printed reports in the effort to be carbon neutral and supportive. The report is digital for the last 3 years. The QR code is available. And what you'll see from these reports are 3 key takeaways, and I think the Minister described it best. Despite all of the challenges historically handed to her and then exacerbated by climate change and globalization, it's health systems that are responsive that are really solving these day-to-day problems. Despite all of those challenges, they've been able to find outbreaks and stop outbreaks. And so I look forward to discussing that more and hand over to Dan, who is one of Australia's premier podcast investigative journalists. But more than that, he's also a comedian. And so I think the term comedian journalist is...
I like to call myself an investigative humorist. That's how I work. Thank you, Amanda. Thank you for that wonderful introduction. Also, thank you to the Minister for planting such a fierce flag in the ground. It's great to be here on Gadigal land in the Eora Nation. And it's a privilege to host this panel on behalf of Resolve to Save Lives, the epidemics that didn't happen. And who better to host this than at a serious global health conference than a comedian? I can't think of anyone else. It makes sense. My comedy is infectious. So you should know better than to laugh at that. Laughter's infectious too. We know that. Look, I hate to go viral of all places here, but, when I told my partner the calibre of people that would be at this conference, she laughed and said, surely the head of the CDC would be more qualified than you to host this. And I said, yes, but did they do their own research? That's the big question. I have. Everything I know about global health, I learnt last night on Twitter from experts. They've got egg icons. That means they're really smart. They've got a lot of numbers in their usernames. That's the amount of degrees they have. I've read dozens and dozens of peer-reviewed memes from my colleagues at the University of Reddit.com. That's how much I know about global health security, and that's why I'm here today. Seriously, my work actually involves a lot of kind of big threats that humanity faces, particularly around climate change. And there's so many synergies between the big issues, namely like human cooperation, speed, simplicity and scale. And this panel today has some of the biggest brains when it comes to getting systems in place for communities to quickly prevent the end of the world. We have on stage today what are effectively the Avengers of global health security. Yes, we're lucky to have them right here. So let's meet our panel for today. For nearly 2 decades, they've worked on the front line of global health security at the International Federation of Red Cross and the Red Crescent Societies. And when they are not focused on epidemic and pandemic preparedness, they like to dabble in portrait photography. But they have mentioned here that they refuse to do your LinkedIn portrait. Please give it up for Maya Scherer. Next up, they are currently serving as the Director of Health Security at the Finnish Institute for Health Welfare. And when he's not preventing and controlling and monitoring infectious diseases, he's indulging in his hobby as a home logistics captain because he has 4 kids. Give it up for Dr. Otto Harbour. And next, since 2020, our next panellist has overseen surveillance operations at Vanuatu's Ministry of Health. Some may say 2020 was a tough year to get that job. Not her. She's used to high-pressure situations because she's also a big fan of scuba diving. Give it up for Joanne. And over a decade, they've been leading teams to help stop the worst possible thing from happening all the time. It's the Senior Vice President of Prevent Epidemics at Resolve to Save Lives, and the winner, I understand, of the mullet-throwing competition of Bribey Island 4 years in a row. She throws fish, everyone. We have a fish thrower. It's Amanda McClelland. Okay, so we've got about 20 minutes to have a chat and there will be time for 1 or 2 questions. So have your questions in your head as we go and we'll come to you. All right, grab a microphone, everyone. You make sure you've got the microphone. We have one less than people, but that's okay. Let's start with Maya. Now, Maya, you run epidemic preparedness, a program called CP3, across multiple countries, you kind of want to bridge the system between communities and health systems. That sounds like an impossible task. What have you learnt through running this program, and what are kind of the challenges you've faced in kind of implementing it?
Thanks. That sounds like a very daunting question. I'm glad to be the first one to be addressing it. So my name is Maya, and I work with the International Federation of Red Cross and Red Crescent Societies. So for you who might not be familiar with Red Cross, Red Crescent, we have 191 national societies in the world, and the Federation is having the hard task of trying to federate them all. And ever since the Federation was created, we've been actually responding to epidemics and pandemics. So we have a very long experience, in particular in responding. But we've been thinking lately, what about preparing? And we were listening to the minister earlier on saying how important it is to actually prepare. So we've been involved in, at the moment, actually, we have 2 programs in 28 countries looking at community preparedness. And what is it that we have learned? Good question. Well, first of all, that it is possible to prevent epidemics. And this is, I think, why we're sitting here. And we're very happy, actually, with this report because it really helps us with our advocacy. Because it is all good to talk about pandemic treaties, but it's also very important to think, what about stopping epidemics in their tracks before they become pandemics? So a big thing that we have learned is that we can prevent epidemics from becoming bigger by doing community-based surveillance with lay volunteers. So I didn't say it, but the Red Cross, Red Crescent has about 16 million volunteers worldwide and lots of staff members as well.
16 million?
16 million.
It's the biggest army on earth.
It is a big army. So we thought that army actually could serve the purpose of stopping epidemics in their tracks. And so that's what we're trying to do in at least 28 countries with the support of USAID and the European Union. But we also have partner national societies in the room. And for example, the example that we have in epidemics that didn't happen is in Somalia, and it's happening with the support of Norway. So besides what the Federation is doing, the membership, the 191 national societies are doing even more. So that's just one example, a successful example, right?
What are like some of the real tangible kind of ways that communities interact with systems? Like, because these are big systems we're talking about.
Yeah, it's quite complex, but actually, when you break it down, it is possible. So, take our network of volunteers. They are not medical doctors. Some of them might be, but the vast majority is not. But they can, if you teach them ways of recognizing the signs and symptoms of diseases, they're able to actually pick them up and then report this to the health system.
Maya, are you saying that even an idiot like me could stop a pandemic?
Of course you could.
Goodness, this is amazing.
I'm not saying you're an idiot, though.
Right, okay, sure.
But yeah, so that's what with the research that they do themselves on the internet and a bit of training from Red Cross, Red Crescent. So what they do is, we're not asking them to become medical doctors because that takes a little bit of training, I hear. But they can focus on, let's say, 5 diseases that they have in their communities and be open to see, if there's anything new emerging in the community, to just pick up any emerging threats as well.
That's great. Otto, I've got a question for you. When we're kind of talking about this kind of big systems interface stuff, a lot of it comes down to coordinations across sectors. Finland went through a bit of a H5N1 outbreak recently. So how did you achieve coordination within your nation?
Right. Thank you very much for the question. And good afternoon, everyone. I believe in building systems or using systems that can be similar in a crisis situation. So that you don't build a new system for a crisis, but you utilize the ones that you have in a normal situation. And I think the collaboration between different sectors, sort of cross-sectoral collaboration, systems have been in place in Finland for a long time, which means that we have constant communication with, for example, the animal health side on a weekly basis with the human health side. Another thing is that within this collaboration, you have to be able to have a dynamic system. The situations differ greatly. You have completely different scenarios that you have to work with. So the collaboration needs to be able to sort of go with the flow, which means that you have to have experience with a long tradition of communication. You have been posed with different circumstances, so it is functional in that way, and also the fact that you do exercises and preparedness.
What does that look like? Exercising a pandemic or exercising an epidemic. What does that look like for you? Does it? Well, you set a date. You go, right. We're going to start an epidemic on May 3rd.
Well, pretty much the exercises are like that.
Right.
So you can have table talk. I mean, of course, you can have exercises including.
I just thought it'd be good if there was a lottery and you sprang it on them.
Exactly. Yeah, I mean, very simple. There are simple ways of running an exercise, and one of the most simple ones are the ones that you sort of sit around a table with the people that you usually work with, and you do a tabletop exercise, sort of a simulation on paper. So these sort of things are.
I play Dungeons and Dragons, so I completely understand what you mean.
Yeah,
but
without the dice, though, usually.
Yeah,
yeah.
That's super interesting. I mean, Finland is a small country. Does that make coordination easier in that regard? Do you think?
I think it requires coordination. That's the whole point. I mean, Finland has had a long history of cross-sectoral preparedness, and I think that's the key reason for that.
What is it that makes Finland so willing to get into the preparation game, into the preparedness game? What is it culturally about Finnish people that they're like, well, we've got to get prepared. Shit's going to hit the fan.
Right. Well, there's a standard answer for that, which is usually given as we've had a cross-sectoral approach to preparedness from immediately after World War II. But I think that's not the actual answer. The actual answer is the one that I already gave you, which is the fact that in a small country you really need cross-sectoral collaboration if you want to have a whole-of-society approach, health and all policies approach, stockpiling approach, you will need a cross-sectoral preparedness strategy. We call it the comprehensive security strategy.
How long did it take to get the H5N1 issue under control in Finland?
How do you define control? It is really complex. I mean, it is obvious to everyone that in a situation when you have two separate segments of society, you have two separate sectors, even if we have close collaboration, it does pose unforeseen challenges every now and then. And I think in the situation that we had in Finland, even with close collaboration, even with sort of routine approach to zoonotic diseases, it's still, every situation is a little bit different. But I think for the Finnish approach, if you consider control to be defined as if you don't need to do any structural changes after that, so the situation has become under control during the structures that you have up and running, I would say a couple of months. But it is a question of definition.
Do you have any tips from America to help with them with their H5N1?
Well, another...
You can say no comment if you want.
I understand.
It's probably safer. This is being recorded, so it's fine. It's fine.
I will answer this. The fact, I think, everyone is, of course, doing the best they can. That's always the...
That is great, yeah. I prefer the Michigan attitude, which is, if you don't test, you don't get cases. It's that simple, so, yeah.
And for example, for the collaboration, cross-sectoral collaboration, the key is that you learn from each other. I think that's the key thing. But for zoonotic diseases, the problem is that if you think about animal health and agriculture on that side, the trade interests become larger every step of the way.
Right.
And in a way, the complexities of that issue is something that on the public health side are not very often addressed or even seen.
Yes, public health and shareholder value are often at odds with each other. Joanne, it's great to have you here. I mean, many cases in the report have connections to climate change, and Vanuatu is a country that is very climate vulnerable. How do epidemics and climate change intersect in Pacific region, and kind of what is your team doing to kind of look at that approach?
Yes, thank you for the question, and good afternoon to everyone in the room. The report that has gone live yesterday in the Resolve to Save Lives webpage was on leptospirosis. So we know that leptospirosis is a disease that occurs in Vanuatu mainly during rainfall, heavy rainfall and flooding. So with climate change, anyone that has been to a small island nation would say that there's been an impact on the climate change, has an impact on the temperature, flooding, even cyclones. Strengths have intensified. So I would say that there is a negative impact of climate change on everything, but given that trying to stop epidemics from happening, I think the Ministry of Health is working closely with other sectors as a multidisciplinary. We formed a One Health committee that somehow deals with all the notifiable diseases within the Ministry of Health. So we try our best to involve as much sectors possible, different sectors, apart from the Ministry of Health, to address this. Yeah, and a lot of things that the Ministry of Health is doing is on enhancing laboratory testing. So we try our best to give out RTTs for lepto to different clinical services or hospitals around the country. And also we use the the Department of Climate Change and Meteorology in Vanuatu has an early warning system for weather. So whenever we know that there's a warning that there will be severe flooding, rain for flooding, we try our best to prevent.
Oh my goodness! Yeah, it's something you don't think about. You're like, wow, there's a cyclone coming. Wow, there could be an epidemic coming. Like, you just got to really, be on the ball with that. Yes. Wow, that's amazing.
It is.
I mean, not amazing, but you know what I mean. It's incredible. And thank you for calling it lepto, because in Australia, that's how we shorten every word. Lepto, mate. Oh, I got a bad case of lepto. Oh. Now, some of these systems that have been put in place are designed for much larger nations. How do you kind of take those systems and apply it to your community?
Yes, so In terms of Vanuatu, if anyone's been to Vanuatu, we would understand that there's 83 islands, and all the islands are scattered, and it's hard to get from one place to another. When there is an emergency, for example, if there's a cyclone, it's hard to get from one place to another to provide service. So in terms of trying to face the different challenges, we have a lot of challenges in terms of human resource, collaboration between the different sectors. Yes, but...
What about Facebook?
We do have Facebook in Vanuatu.
Is that a challenge?
There's a Facebook page for the health promotion for Vanuatu, and it's called Health Promotion Vanuatu. So we normally post information on there, so anyone across the country can have access to that, yes.
Yeah. I guess what I'm talking about is misinformation. Anyone here, feel free to jump in, but is social a problem for you?
Yes,
Yep.
at times when during the pandemic we have a lot of misinformation that we had to deal with, but that is something I don't think Vanuatu alone is experiencing. I think the other countries as well.
Globally, Otto?
We have exactly the same thing in Finland, and I think all of us here in the room have the same experience that things have changed during the pandemic. And I think one of the indicators for that, maybe not an indicator, but the way that it's seen in Finland at least, is the fact that we've had extremely small percentage of the population that have been anti-vaccine. And this has changed a lot during the pandemic, and I think the disinformation entity is something that we're still very much grappling with on how to respond to that.
Yeah. Amanda, I've got a question for you. Might grab Maya's microphone there. This is the third report of the epidemics that didn't happen. It's such a great name. Why call it that? And what does that name do for you in terms of creating buzz around this issue?
It's about changing the conversation. I think so much of what happens in public health is invisible, and I think we were challenged by donors when we first started working in this space in terms of how we showed results, and the results are that nothing happens.
I gave you $10 million and nothing happened.
So I think part of this was really in response to working with some of the more traditional donors and trying to explain that we were trying to make sure that nothing happened. And so please give us more money so that more of nothing can happen. And so I think it was about trying to change the conversation and the way that we think about success, but also I'd come out of West Africa Ebola like many of you, and I'd gone through multiple hot washes. I think I got more PTSD from the hot washes than I got from the actual response.
Yeah, sorry, I'm not from this world. What is a hot wash?
Oh, sorry. It's a shower. It's a long shower. No.
Is it a shower with I assume it's a shower with a really attractive person. That's.
Of course. Sorry, my apologies. A hot wash is when we review what went wrong and what went right. An after-action review. But there was a great methodology when I worked in malnutrition of positive deviance, looking at the things that went right. And so actually we worked with Georgetown University, and instead of looking at all the things that went wrong, we started to look at things that went right. And you'd be surprised, we started to see some consistency. Good, protected frontline healthcare workers that had clinical suspicion, that recognised those febrile cases as they walked in. Health systems that were listening to those signals, whether they came from community workers in the Red Cross, whether they came from primary healthcare, frontline healthcare workers, but a system that responded to those signals. And we started to see a pattern in outbreaks that didn't happen, hence the name.
Yeah. I've seen a lot of folks in the room, some of the folks from your team with 717 badges on, and I know you've recently launched this global call to action for 717. The Minister mentioned it before in their remarks. Can you tell us a little bit about 717 and how does it relate to the epidemics that didn't happen?
Well, we're all about the branding, Dan. Epidemics that didn't happen, 717, short, sharp, no. 717 really came from a lot of the learnings from epidemics that didn't happen. And one of the key lessons from the first and second report was timeliness. When we found outbreaks quickly and stopped outbreaks, they didn't happen. So we started to focus on that subsystem, that early detection, early response system. and started to think through how do we focus on those systems? How do we build those capacities? And so we looked at timeliness indicators. Many of you, the epidemiologists in the room, these are not new, but they were complex. It was very hard to explain to a Minister of Finance what we were doing across 19 technical areas, why it was important that we worked across sectors. And so we combined that research around early detection, early response with some of the lessons in the bigger public health areas like HIV that had been very successful with models like 90-90-90. You might not have seen that on Twitter in your research, but
Thank you, yeah.
it's a thing that the audience will know about. And so we tried to combine our experience from epidemics that didn't happen with our advocacy and communication approaches, which led to this package of activities we called 717.
717 and, you know, some of the things you're talking about, particularly in epidemics that didn't happen, they all seem very simplistic. You know, we live in 2024, you know, we're surrounded by the internet and AI and technology, but kind of these basics are very kind of on the ground, human to human. Isn't this like just really simple stuff that can be solved by, you know, a like a supercomputer?
Yeah, well, supercomputers. Look, I'm a simple girl that likes to throw fish back in the day. Thanks for bringing that up, colleagues. But you're right. I think Leonardo da Vinci first said the sophistication is in the simplicity. And Steve Jobs turned it into a billion-dollar industry. And my boss, Tom Frieden, turned it into our core values: speed, simplicity, and scale. We're only going to match the scale that we need to keep the world safe if we keep things simple and do the basics well. And I think about the work that we do as a team sport. We talk about multi-sectorial coordination. We use a lot of these buzzwords, but actually I think the director of the CDC published a great article a few weeks ago calling for public health to think about the work as a team sport. And teams that are successful do the basics well. You can't win championships with supercomputers, right? You win championships by doing the basics well and consistently, and then using those special skills when they're needed the most. So there's a room for supercomputers, but this is about people doing the same things consistently, managing misinformation on Facebook, working with communities consistently and building those core capacities.
Right, thank you, Amanda. All right, we've got time for a couple of questions. Chris is over here with a microphone. If you've got one or two questions, then hit Chris up. I've got a question for you, Amanda. Are you still the reigning champion mullet thrower in Bridie Island?
Unfortunately, I'm not. I've gone international, and the mullet throwing leagues internationally is not, like many of our sports in Australia, no one else really understands them. I can explain cricket. Yesterday I explained bin chickens, Dan.
No one understands what bin chickens are. Yeah.
So I'm happy for that cultural competency, but no, fish throwing is not internationally recognised.
Do we have any questions for the brains on our panel here? Yeah, up the back there, sir, with the microphone, with the moustache up the back there. Yep.
Run across.
There we go.
Hi, I'm Jawad Asghar, GHSI, Pakistan. My question is about 717. I'm working on pandemic preparedness for years, and every new era, we have new indicators to show our preparedness. Unfortunately, none was associated with the good performance when the pandemic hits us. How confident you are that 717 will actually make us more protected the next time we have a pandemic? What I'm saying, asking you, how you are monitoring and evaluating your indicators, that they are the right indicators and they are not just made up indicators by many people, which we have unfortunately long experience with. Thank you.
I guess this goes to the first 7 in 717, Amanda.
Yeah, I think we need to be careful that 717 is a silver bullet, right? This is a complex, wicked issue that requires multiple subsystems to work, and they're not just health systems. We need our political system, our economic system, our social system, as well as our climate to all work. What we think 717 does is help you understand how you're performing consistently and help you understand where you can continue to improve. It's not about the number. Right? We could have made it 10, 22, 6, but it's not as catchy. Now, There is a science behind 717. It is evidence-based. We're happy to share. We've got an event tomorrow where we're able to share the evidence-based why we picked those numbers. But essentially, I want to be very careful because the 717's kind of getting out there and it's everywhere. It's not a silver bullet. If you find a cholera outbreak in a refugee camp in 7 days, you are too slow, all right? And so this isn't about waiting. I don't want anyone sitting in the break room going, well, we've got another 3 days, so just relax. Amanda said 7 days was quick enough, so let's just wait and see what happens. This is about a culture, a workflow of thinking about how we can be better every single day. That's what 717's about. So for those epidemiologists in the room that has lots of questions about the definition and about the data and try to let that go a bit and think about the culture of continual improvement. How do we get out the door faster? How do we engage with communities better? How do we make sure that our systems are functioning and working together? And if they're not, how do we fix them?
Great. Over here, yep. Then we'll go up to you.
Thank you. Hi, my name is Oyoronke and I work for CEPI. You mentioned at the beginning, Amanda, that one of the reasons Resolve started working on the epidemics that didn't happen was to show donors what could work. Third year of the report or third version of the report, have you seen a change in how donors, but also governments, invest in preparedness? Have you seen a switch from, if it doesn't work, then maybe there is more money to put in this area of work rather than waiting for the response?
Ooh. It could be a question for anybody, really.
Yeah, a question for anyone. Look, I don't think it's just for donors, right? I think part of the idea of putting the report digitally and using storytelling is to make it open for people like Dan who are doing their own research. So when we asked Dan to join us, the fact that he found the report engaging, I think is part of it. The donors are one audience, but what's important is civil society. I'm looking at our GHAI colleagues who have been doing some fantastic work with civil society. We need the community to understand that public health is important. Just because we're invisible to them, they don't see us until things are at their worst, doesn't mean that they shouldn't be advocating to their politicians that we need more money or that we need to do better. So we continue to work on this in a number of different ways. We use the report to advocate with governments to do better, for communities to be more engaged and to, for donors to understand that we can demonstrate impact by showing nothing.
We've just got one last question. The lady in red up there, really quick, and then we'll
Thank you so much, Dr. Nadia from Pakistan. I'm working for the Border Health. So my question is this: I'm really interested to know that how we can align the concept of 717 for the surveillance, for the cross-border infectious disease prevention. So I will appreciate if you can enlighten us with this. Thank you.
I look forward to seeing how Pakistan uses it and learning from them. I think part of the approach of 717 is learning from countries. We've started to work with a few countries about what that means, but this needs agile, brave political leadership to share the numbers outside of your own house. So cross-border collaboration, we see huge value and transparency in sharing the 717 numbers with your next door neighbors. If there's Uganda in the room, give them a shout out. They shared their Ebola numbers during the middle of the outbreak. It was very brave. It requires leadership and political skill to be able to say, hey, we could have done better and this is what went wrong. And so I look forward to seeing from the countries in the room how brave they are and how open they are to share their transparency with each other and with the public.
I've been using 717 at home with my laundry basket. For 7 days, I smell it to make sure it is the laundry basket. And then day one, I report it to people in the house. And then over the next 7 days, I proceed to clean the laundry. So that's how I use 717 at home.
Very helpful, Dan.
Yep,
thank you.
Yeah.
And that's why we need more communication with communities, and doing your own research is not really recommended.
Thank you, everyone, for spending your lunch break here with us to talk about the epidemics that didn't happen. And the report is sensational. It is great. I absolutely enjoyed devouring it. And please, scan it, scan the QR code so you can get a copy of the report yourself. And please thank all of our panel here today. And Amanda, did you want to wrap up?
Yes. Just a huge thank you to the panelists and to the countries that contributed to the third report. We look forward to sharing it all with you. Thank you. I hope you're all enjoying this week. I've had some really challenging, interesting and disruptive conversations in the last 2 days. I hope this positive aspect on the work that we do helps you not only to be inspired by your own success and just take a minute to recognize that you do a great job. And I look forward to really showcasing more epidemics that didn't happen next year.
Great. Now we can all go have a hot wash. So thanks very much.